Hi, everyone, and welcome to NDD's webinar that is titled The Importance of Pulmonary Function Testing in Asthma. My name is Jamie Burgess, and I'm an RT with NDD.
And I'm Darren Fitzpatrick, and I'm also an RT with NDD. And joining us today for our discussion is Mary Hart, who is the Director of Research at the Allergy and Asthma Network.
Hi, Mary. Thanks for joining us.
Hello. Thank you for having me.
Absolutely. A little bit of housekeeping to get us started. As always, there will be that question and answer window open for you to ask questions as they come up throughout the webinar. Just know we're going to wait until the end of the presentation to address those. And there will also be a post-webinar email sent to everyone that's registered that'll have Darren and myself's contact information. And then there will also be a recording of this presentation if you're not able to catch it live. All right, so our objectives for today. So first, we're going to start with a Q&A session with Mary Hart on the importance of lung function testing in asthma. We're going to hear from her about the Allergy and Asthma Network and their mission. We're going to understand the role of PFT testing in diagnosing and managing asthma. We're going to learn also how often PFT testing should be performed on these asthma patients, and then also review the guidelines on PFT testing after their diagnosis.
And again, we just want to take the time to introduce Mary Hart. Mary Hart is a very good friend of NDD. She is not only a fantastic registered respiratory therapist, a certified asthma educator, and along with many other credentials, we just want to take the time to thank Mary. Thank you for being here. Her work at the Allergy and Asthma Network, she's the Director of Development, and we just thought she would be the perfect person to help us today go over PFTs with asthma. Hey, Mary, can you hear us?
Yes.
So we're going to go ahead and let Mary do tell us a little bit more about the Allergy and Asthma Network and your history of being a respiratory therapist.
Sure. So there's some of you on the line that may already know me and have worked with me in the past, but I'm, like she said, a respiratory therapist, over 35 years experience, everything from bedside care to management, outpatient lung disease management, research, and then working at UT Health Science Center in San Antonio as a professor. And I got the honor, and that's kind of one of these things, of being the faculty who took care of pulmonary function testing in the lab for all the students. In other words, I was the low man on the totem pole for that. So I've had quite a bit of experience with that. And so my title at the Allergy Asthma Network is Director of Research. And I want to tell you a little bit about the network. We're the leading nonprofit organization, and our mission is to end the needless deaths and suffering due to asthma, allergies, and other related conditions. And the way that we do this is we have different programs in outreach, community outreach, education for both patients and healthcare providers, patient advocacy, and then something that I'm involved in a lot is the research that involves a lot of patients working along in all areas of research, from focus groups to patient ad boards to working with pharmaceutical companies and developing protocols for future medications that are being developed. So
definitely busy.
Yes. So let's go ahead and go to the next slide. Yeah. Okay, and I can't talk about spirometry or asthma without first talking a little bit about the prevalence of asthma. In today's world in the U.S., we still have people dying of asthma. We have 10 people that die each day of asthma. As you can see in this little poster that we have, 3,600 deaths a year, and 75% are at risk is our African American communities. They're 75% higher than the white communities. 24 million people diagnosed, and there's a lot of people that haven't been diagnosed, and that kind of leads me into our conversation today. But as an asthma educator, when I first saw this, I was shocked, but not really, and that's the fact that 71% of people that have metered dose inhalers or different asthma medication delivery devices misuse them. And there's been studies that were done along with respiratory therapists and nurses and physicians that actually said, guess what, you guys don't know how to use an inhaler either. So it's really important for us to take a look at these things and figure out what we can help people with and change these numbers for the future.
Absolutely. And that leads us into our Q&A with Mary. And again, we're thankful that she's here and having an expert in asthma. We knew that with it being Asthma Awareness Month as well, that Mary Hart would be the best person to have on here. So again, Mary, thank you. And we'll go ahead and start with our Q&A. And so our first question for you, Mary, is what are signs and symptoms of asthma that would trigger you to order a PFT test on a patient? What do you look for?
Sure. So going back to my discussion about it being an outpatient clinic, let me just start with that. My experience is seeing people that don't come in with asthma tattooed on their forehead, right? Or COPD or anything else. And so we have to get to the root of why they're there. Is it because they have a history of asthma in their family? We do a complete assessment and physical with them. And we're looking for classic signs and symptoms of asthma when we're doing that. And I have those listed. These come from the NIH, and shortness of breath, and sometimes shortness of breath that would limit your activities. You know, if you were exercising before, but now you're not, that might be something, along with the chest tightness. And I've had patients say chest pain. And when, you know, a lot of us hear chest pain, we think cardiac, but a lot of times patients describe the chest tightness that they're feeling as a pain in their chest. So we have to be aware of that as well. And then if you wake up at night due to asthma symptoms such as the shortness of breath or the chest tightness or coughing at night is a very common symptom, and wheezing. And as everyone knows, wheezing is that whistling sound that you hear whenever you exhale. And then on the list too is coughing or wheezing attacks. They're worsened with respiratory viruses. So those are the things that would trigger us to think, well, you know, maybe they have asthma. So the next thing we need to do, and is an essential part of, is testing, doing PFTs and starting with spirometry. You know, it's important to have that to get the diagnosis of asthma and for the management of asthma. So go ahead and go to the next slide.
Yeah.
So with that, it comes the, you know, what do you use to diagnose asthma? So our next question is, what parameters are used to diagnose asthma? What is the importance of that post bronchodilator testing?
Okay. Well, so I want to kind of back up a little bit too and say spirometry is important. And what if you're seeing a physician that doesn't have spirometry in their office? And they have those symptoms and they have a family history and there's something going on. That person needs to get to a clinic or a physician or somewhere that they can get that spirometry testing performed. So understanding the values of spirometry, and we're looking for an obstruction with asthma. So we'll go over a few numbers here in just a minute, but I think that it's important to say that regardless of the numbers you get, you need to know whether you've had a good test performed or not. And so the person that's doing the test, or if you've received a copy of a test from another physician's office, you want to make sure that the guidelines were followed and that the patient understood how to perform that test. And so the things that we look at, and I've included on here a couple of graphs. The first one is one that I like to, whenever I'm doing spirometry, is to be able to see what the flow volume loops look like. And as we're trained as respiratory therapists, there are different shapes based on whether it's a normal spirometry flow volume loop or restriction or obstruction. And you can kind of see that concave part there on the obstruction loop. So that's something that I might be visually being able to see whenever I'm doing a test. And that's what I would expect to see if there was obstruction. So having that available. But we're looking at the force, the vital capacity, number one, how much air can you forcefully blow out of your lungs, right? And if there's an obstruction, then the FEV1, the forced exhaled volume in 1 second, may be lower than normally predicted for that patient. So we're looking at FVC, we're looking at FEV1, and then the ratio between the two, the FEV1 FVC ratio, also if it's lower, then that could give us an indication that there is obstruction. So those are the things that we look at in spirometry. And then
Okay.
to go, and I want to say too that, not just the numbers, but know what your predicted reference sets are for your patients. There are different ones, and you might get a little bit of variation in the difference if they've been to one physician and they're going to another one that are using different reference sets. That we're looking at using the lower limits of normal for the forced vital capacity, the FEV1. So we're taking the predicted versus the patient's actual and coming up with the percent of their predicted there.
Yeah, good point to point out. It's definitely important to remember that, because many physician offices, some will use the GLI index, some will use the NHANES. We still have some that use CRAPO, and that can make a big difference. And I know on a lot of reports, state what you're looking at. So that's a great point to bring up, is sometimes those numbers aren't matching up, but simply it's just because that predicted set is different. So definitely a good point.
To talk a little bit more about that just for a second is that, so my experience in research is the fact that we're using GLI now. And so if you're trying to recruit patients with a certain, level of obstruction, you need to make sure that they've been tested with the GLI.
Right. And for those of you, absolutely. Go ahead, Mary.
No, you were going to say something for those of you
who don't know, the GLI is the Global Lung Index or Initiative. Is that right, Mary? That it's a predicted set similar to NHANES. I call it the glorified NHANES, the most up to date. So if you are not familiar, or if you're still using NHANES 3 on your spirometer, I know that's still a recommendation, but I know the GLI is really where ATS is pushing clinicians to use.
Yeah. In all the research clinical trials that I've been involved in, that's what they've been using as well. And the other thing is that it goes down to age 3 and up to age 80. So it has a broader range for predictives. Okay.
Perfect. We'll go to the next slide.
So the next one is about the question about doing a post-bronchodilator, and that's where we're looking for airway reversibility. Yep. And so you would obviously, if your patient was on any type of, we'll say asthma medications, you would have them hold them so that if you're doing this pre and post testing, that it wouldn't impact the difference there. So we're looking for 15 minutes after giving a short-acting beta agonist, a % change in FVC and or the FEV1 of greater than 12% and 200 mLs. And this is an example of a study that was done on a patient, and it had a change of FVC was only 10% post bronchodilator, but there was an actual change of 300 mLs. And FEV1 change was 24%. I think it was close to 550 or 560 mLs. So it met that criteria. And then in looking at the ratio, if it was less than the normal predicted, we're looking for something that, and so with this, we got our diagnosis of asthma because we have an acceptable effort. We have a low volume loop that's there. We see the significant change from pre and post bronchodilator. But, this patient was a typical easy asthma patient. And I'll tell you, in my lifetime, I've seen a lot of different kinds of patients, and it's not always quite so simple. So
and we have I was going to show so we're doing something a little bit different this time with Mary, and we're going to do a poll question for all of our clinicians and viewers out there. And so we're going to put a question up, and you guys could type in the answer in the comment box. Is that where they put
it's actually gonna pop up over here under the poll section. Should be coming your way now.
So for all of our viewers on there, if a patient is symptomatic and the pre and post does not show any evidence of airway limitation, can asthma diagnosis be made? Much like what Mary just talked about, the 12% difference in the 200 mLs. So if that doesn't show up, can you still make that diagnosis?
I'm seeing our results over here. Give you guys just a second. So far, we have about 57% saying yes. Give everybody a chance to vote here.
And then we'll have one more poll question after this, and then we'll Is it after this one, Jamie, or is it
It's a couple
a couple
questions.
slides? Okay, so we're gonna do 2 poll questions this time.
Make sure you guys are paying attention. All right, I'm going to go ahead and close out this poll, and we have a resounding 61% saying yes.
And a 25% that says no, and a 14% that says unsure.
So do I get to speak here about
You get to, oh yeah, yes.
I was just going to say the way that I would answer would be, no, we do not have a diagnosis, because again, in order to get the diagnosis, we want to see that reversibility of 12% and at least 200 mLs in the FVC and or the FEV1. And that would give us the diagnosis along with the symptoms of asthma, that they had airway reversibility.
Okay. Go ahead to the next question. Okay, Mary, how often should an asthmatic patient have PFT testing?
According to the guidelines, it says that PFT, or at least for asthma, spirometry testing should be done every 1 to 2 years, and more frequently for asthma that's not well controlled. And that's what I was going to say. It's very rare that we would see in our office a patient that we wouldn't do another spirometry on for a couple of years,
right.
Especially in those difficult to treat or difficult to control patients, or if you're still going through the process of trying to get a diagnosis. Mm-hmm. Maybe they have some other underlying issue that's going on, so you would need to continue to do spirometry. And also, if you're starting a patient on a trial of medication, it would be good to be able to track their response to the medication by using the spirometry.
The spirometry, okay. Mm-hmm. And that leads us to our next poll question, or is it after this one? Is it one more for the poll?
Nope, it's this one.
Okay. So we'll go ahead and push that question up. Our next poll question is for you guys. What further tests can be performed to rule in or out the diagnosis of asthma? So when that's much like what we spoke about before, sometimes that post-bronchodilator will not show a response, but that patient's symptomatic. So what would be another test that you could do? A full PFT, including lung volumes and DLCO, bronchoprovocation, much like methacholine, mannitol, pheno testing, or all of the above. So go ahead and we're calculating our responses now. These are fun.
I like these.
So it's a great group. We have a lot of RTs and a lot of physicians, or I should say a lot of clinicians on here as well. So this is a great group to ask these questions to.
Yeah. Absolutely.
So we'll give it a couple more seconds. As of right now, Mary, we have about 65% are saying all of the above, 23% are saying full PFT, including lung volumes and DLCO, 7% bronchoprovocation, and 5% pheno. So we'll go ahead and close out that poll. So a leading is, all of the above was the correct answer, if I'm right, Mary.
Yeah. Exactly, all of the above, but obviously you wouldn't do all of the testing immediately,
no.
Right? You're going to be thoughtful and say, okay, so this patient has symptoms. We did pre and post bronchodilator testing. If you are sure the patient had not used their bronchodilator or their long-term medication or their controller medication within the time period they were supposed to, then personally, what we typically would move to would be methacholine challenge testing. Mm-hmm. And if we got a diagnosis there, then, we stopped, but a lot of times we would go ahead and do a full PFT just to see, right. was there any change in DLCO and what did their lung volumes look like, and was there any hyperinflation and so forth.
Right.
So all of those things are needed. And so additional testing, we have DLCO tests performed, again, to differentiate between asthma and other lung disease. In asthma, it's typically normal or it can be high. Mm-hmm. And then pheno testing, that's something that a few years ago in our lung clinic, we started using pheno testing on all our asthmatic patients to evaluate for inflammation. We tried to use it as an indicator of whether they were being using their medications like they were supposed to, whether they were being compliant. It doesn't always give you the right answer, because as you probably know, not all asthmatics have the elevated FeNO numbers. It depends on the type of asthma. And then allergy testing, because if you're having things that are around you in your environment, or outdoors, or cigarette smoke, or any of those, there's a number of things that you can be allergic to that can make your asthma worse. We need to find out, do you have allergies? So allergy testing. And then types of labs that we would do would be sputum and blood test, and we're looking for asthma phenotypes and so forth. So those are the types of the typical tests that we would do with a patient that was newly diagnosed with asthma.
Okay, perfect. And we'll go to our last question for you, Mary. What education programs are offered through the Allergy and Asthma Network for clinicians and families? Why is it important for us clinicians to stress education after a diagnosis for patients and their families?
Sure. So if you'll go ahead and show the next slide, as you, I think you mentioned, I'm a certified asthma educator, and I like to have all the tools available to me for every type patient, whether, you know, the different age, or depending on if they're a visual person or they like to read a lot of content, or so having tools that you can review symptoms and patient triggers, and all about medications, and an asthma action plan. I mean, we need to know, once you've been diagnosed with asthma, what's the plan to control it? It's not like you get diagnosed, you get a medication, you're all better, and you know, a lot of times people will think, well, I'm cured, but as we know, asthma can't be cured, but it can be controlled. So having all of these tools, and they're all available through the Allergy and Asthma Network. And I put communication on there because sometimes patients have a hard time talking to their physician or their their nurse practitioner. And so just working with them on, how do I communicate what I'm feeling to my doctor, and don't be afraid to tell them the truth, or don't be afraid of what they may say back to you. And then there's lots of barriers that our patients have. So being able to discuss all of those, and you can find a lot of information on our website about that. One of the things that we are just now beginning to offer is a telehealth asthma coach. And so that's up and coming for us, and we have programs for school nurses and
it's probably
educators.
Really important for parents too. I mean, Jamie's got a little boy that's an asthmatic, so she's an RT, so that helps out. But some of us, some parents out there, and I'm sure many of the RTs on here have been on the football sidelines. You're watching kids, just shake inhalers and puff them in over and over again. You're like, oh my goodness, can I just go down there? Because I just don't think, one office visit is enough. And that's why your network, Mary, is so important for us clinicians to educate the families that there's more to it than, like you said, just a diagnosis. Here's your inhaler, go home. There's so much more. So absolutely.
And so this is one of my favorite tools. And even before I started working with Allergy Asthma Network, this was a poster that I took, and it's like an 8x10 size. And so it's something that you can, they come laminated, they come in paper, however. And you can use that and show it to the patient, because 9 times out of 10, they don't even know the medication they're on or what the dosage is, so they can point and use that. It also gives them a good indication or idea of all the different types of medications that are available to them.
Absolutely. So, I think some people might be confused. It's just one type of inhaler. You're good to go.
I used to get it's the purple one a lot.
Yeah.
So.
Yeah. Yeah, and look at
all thing.
Yeah, you see all the different colors there. You can't keep up with all. And they change. I
was gonna say they've changed a lot, even in 20 years.
Yeah. So I think I have one more slide. About asthma tools and for healthcare providers and for patients and families. And you see the understanding guide there. We have different ones for asthma, allergies, atopic dermatitis. The latest one we have, I think, is related lung conditions. And those are all free. You can go to our website and download them and use them in your offices or with your family members. It has everything that you need to know about asthma in terms that most people understand. It has action plan, asthma action plan included in it. It has the poster of the medications, and it has a place for them to maybe journal and keep notes, because that's important
perfect
to know too.
Yeah.
And having all of that in one place for me made it very easy and simple for me to educate my patients. And then a couple of things. You mentioned that this is Asthma Month.
Yep.
And we actually, from Allergy Asthma Network, we launched our new website. So please visit it. The website's
beautiful.
at the bottom. We also started our, it's called the Asthma 360 Registry, and that's for individuals that have asthma to join and take a quick survey, and we're going to collect information over a 10-year period of time.
Wow.
And try to have a database of information that we can use to take it to the further step in terms of research. One of the things that it would allow me to do as a director of research is to contact people and let them know that we have, there's an opportunity for them to enroll in a different, maybe a clinical trial or something. So it's a two-way street.
Wow. Okay.
And so it's easy to do. Just go to our website and go to Asthma 360. If you have asthma, you're over the age of 18. And then also we started the COVID-19 registry. We're trying to track people over 100 days during this. It doesn't mean that you have asthma. You don't even have to have asthma to take it. But it's trying to identify the way we feel, the changes we've made. How's the isolation affected us financially? What's going on? All the things that we're going through right now. And then another study we just recently started is a cannabis study, and it's with people that have asthma, and how cannabis may impact them, either good or bad. It helps with pain and that sort of thing. So those are, and then I've already mentioned the asthma coaches. And so we also have monthly webinars similar to what we have here. We usually have really good speakers in all aspects of lung disease and issues that are going on. We also have a shared decision-making tool, because one of the things that we advocate for, of course, are patients, and patients need to be able to share in their decisions of their health. And so we've worked with physicians and patients in learning how to communicate effectively. And then I'll just leave it at that.
Okay.
There's so much more.
There's so much.
Just
I know. Wish we had even more time. And what we'll do is Jamie and I will quickly. Mary's going to stay on here. Mary's not leaving us. I want questions going. Whether you listen to Jamie and I over the next few slides, real quick, it's okay. We won't take it personally. But we'll get to questions with Mary. So if you guys have questions, please go over to what Jamie had discussed. Under the housekeeping, there is a window for you to ask questions. Go ahead, start typing those in. We'll continue up real quick with the presentation, and then we'll come back to you, Mary. So hang tight if you don't mind.
Yeah.
Okay.
All right. We just wanted to take a brief moment before we wrap up just to highlight NDD's Easy One product line. On all of our past webinars, we've really been featuring our Pro and Pro Lab devices, and those are our full point of care PFT devices. You've seen us do the DLCO demonstrations, and so we think at this point you guys are pretty familiar with that device. Our spirometry devices, on the other hand, you can see those all three of those products pictured there, are our Easy On PC and then the Easy One Air device. All of these products feature our patented TrueFlow technology. Those give you the most accurate results. There's no calibration required, no warm-up time, and our software is just so easy to use, and the updates for that software are free for the life of the device. If you guys are with an allergy asthma office or a general practice that is not currently doing spirometry, and that's something that you want to have a discussion about and really explore these options to see if something would be a good fit, absolutely reach out to Darren, reach out to myself, and we can set up a time to just go into more depth and to talk to you about those things.
Absolutely. And just we just want to go over the key takeaways that we have with this great webinar today with Mary. Number one is understanding how to diagnose and manage asthma and lung function testing. Mary did a great job of going over those really specific parameters and those questions to ask your patients. And another one is to understand the guidelines in place for initial treatment and management of asthma. And it really sounds like the Allergy and Asthma Network gives a lot of support for that when that treatment's coming, when the treatment is given to the patient. So definitely go back and check out Mary's website. And understanding the benefits of NDD's Easy One Spirometry and PFT products, just like Jamie went over. We have a lot of great spirometry, from portable spirometry to ones that can be on the laptop and Bluetooth and really portable. We have a lot of people taking these spirometers into patients' homes right now due to COVID. So definitely check us out. Go ahead, Jamie, and we'll there's our Jamie and I's emails. So if you need a web demo, if you need brochures, anything like that, let us know. I know we have a lot of friends on here that are great return to our webinar friends, so we appreciate that. And we'll go to questions real quick.
Yeah, absolutely. Bianca, do you want to hop on?
Yes. Hi everyone. Mary, thank you so much for the great presentation. And we do have quite a few questions flying in here, so I'll just get started. So the first question I have here is from Mary Kay, and she asks, if a research study guideline for recruitment asks for a ratio post-bronchodilator of less than 70%, do you use the percent predicted or the actual percent in screening?
You would use the actual number is what you would use. It's not you would use what the patient actually achieves.
Right.
Yeah.
Okay. Perfect.
Great. Perfect.
Thanks, Mary, for your question.
We have another question here. What is the optimal way to diagnose asthma using spirometry parameters considering GINA guidelines, which include FVC as an indicator, which is rarely achieved?
Are you talking about the 12% and the 200? Is that what they're talking about? Or
I think. Read it one more time, Bianca. I'm
right,
sorry.
Yeah, they don't specifically mention what is the optimal way to diagnose asthma using spirometry parameters, considering the GINA guidelines, which include FVC as an indicator, which is rarely achieved. And this is from Allie. So Allie, if you're still on and you have a little bit more information you can provide on that question, that'd be great.
But I'm guessing it means that 12%.
He did say yes, 12%.
Okay, 12%, yeah. Yep.
Yeah, I mean, with that, I would go back and look at my patient. You know, was the test done properly? Did they withhold the bronchodilator? And then I would go ahead and move forward with another type test if they're still having symptoms and we didn't achieve that, because you still need to get the diagnosis.
Absolutely.
Perfect, thank you. We have another question here from Sarah. If one's asthma is very mild, should they still get a PFT done every 1 to 2 years?
So I'm going to answer that like a politician, maybe. And the reason I say that is because I have a daughter that has asthma. She has severe asthma, so she has a lot more than one a year. But just to keep a check on your asthma and see if things are changing, it's important to go ahead and have that. Some physician offices just do annual. Just depends on your physician too and how they want to manage you.
Absolutely.
Perfect,
Bianca, do you have another one?
So I'm just going through our list here. I think we've gone through. We do have a couple people here asking about filters, and what we can do after this call is get you guys connected with Darren and Jamie separately to answer those questions. But I do see a couple of you guys, and we'll make sure to address those questions.
And we have good answers for you. So we do have good answers. So shoot us, if you guys can grab Jamie and R's email and just email us that question, we'll get back to you. And Mary, I have one question for you that I didn't discuss with you earlier that came up. When Jamie and I go out and train, or any of us go train, a lot of times we get asked by a physician, if the patient's still above 70% of predicted on their FVC or FEV1, should they still do a post-bronchodilator? I feel like a lot of physicians wait for that 70% mark and then decide if a post-bronchodilator should be done, where in my work history the last 20 years, I always felt like your pre and post should always be done, even if the patient's symptomatic, just because that patient might be having a good asthma day and they're at 98% predicted, and you give a bronchodilator and they actually go up to, you know, 125. Exactly. So do you agree with us on that? That if a patient's symptomatic?
I always agree. Yeah, that I would always agree with that. That's a really good point, because I've seen patients that, you know, they're obviously having symptoms, but their spirometry is perfectly normal. You give them a bronchodilator and they are way over 100% of predicted, and that's where they live. So you can't always go by that 70% or.
Okay, good. I'm glad you agree, because that's what I tell people. I'm like, if it were me, if the patient's complaining of some symptom, obviously, like I said, they can look really good on paper, but until you do that bronchodilator and all of a sudden they're where they should be is 130%. And we see those patients, a healthy patient, we see at 130% of predicted. So thank you, Mary. I meant to ask you about that earlier. So
I'm glad we agree on that.
That could have been really awkward.
Well, thank you guys all so much again for joining us today. We hope you guys learned something, maybe had a little fun. We had fun kind of playing with our new toys here today. Mary, again, thank you so much for joining us. And we had Mary's contact information in the slide deck. So definitely check out the website. If you have specific questions for Mary, her contact information was in the slide deck. I know she'd be happy to talk with you. Everybody stay safe, stay healthy, and we will see you guys all again next month. All right.
Thanks, Mary.
Thank you, Mary.
Bye.
Have a good day, everybody.